So I want to start by welcoming everybody to the session on the Headz ED and community consultation. So this is being brought to you in partnership with the Ontario Centre of Excellence for Child and Youth Mental Health and Infant Mental Health Promotion at the Hospital for Sick Kids. And for those who may not know me, my name's CHEO and I'm the Director of Infant Mental Health Promotion at the Hospital for Sick Children. So I want to introduce our panelists today, and we have three panelists who will be presenting today. So first of all, we have Dr. Mario Cappelli joining us, who is a child clinical psychologist and has been specializing for the past 25 years in work with children, youth, young adults, and their families. He's currently the Senior Clinician-Scientist at the Ontario Centre of Excellence for Child and Youth Mental Health, and an adjunct professor of psychology and psychiatry at the University of Ottawa. Dr. Cappelli has a passion for teaching and research and has trained PhD psychologists and health clinical scientists. His research focuses on the mental health of children, youth, and families, and specifically how to best identify needs and to deliver mental health services to children and youth in an effective and integrated way. His research is funded through public agencies and private foundations. Also joining us is Dr. Ashley Radomski, who is a CIHR Health Systems Impact Post-doctoral Fellow at the Ontario Centre of Excellence for Child and Youth Mental Health. Ashley's research approach prioritizes integrating and managing the perspectives of various stakeholders into her projects to strengthen the methods, analysis, and communication of findings for her audience, and to understanding how interventions work and therefore how they can be optimized to achieve desired outcomes. Ashley has a research background in neurodegenerative disease, e-mental health, and most recently, clinical care pathways for young people and their families. And our final presenter is Joel Schryer, who is the Program Manager of Mental Health and Quality Improvement at Children First in Windsor, Ontario. This is the Children's Mental Health Agency serving children from birth to the age of 6 and their families. Joel has clinical experience working with children, youth, and families from birth to 18 in various children's mental health settings. He believes a community approach to supporting families and helping children be successful across the multiple environments is critical.
Thank you, Chai, and the folks at Infant Mental Health Promotion and at the Center for inviting us to present on some of the work that we've been involved with provincially as well as beyond our province, and hopefully some of this work can serve as a background and serve as a foundation to some of the ideas that we've talked about in the past and moving forward. I have to admit, I feel like a bit of an imposter today. You know, I do work clinically with children and youth, and I've been working in this area for a while, but an imposter because most of the work I do is actually with school-age kids and older. So clinically, not a lot of work with the under 6, but certainly, you know, some work. And I'm speaking to, 250 or so plus of experts in the province. So hopefully I don't embarrass myself too much, and I welcome absolutely any feedback from the audience, because you guys really are the experts. See if I can get my cursor to work now. There we go. So even though I'll be spending a bit of the bulk of the time talking, there's a number of folks that have contributed to the presentation, and Joel and Ashley will also chat a little bit along the way, but I do want to send a special thanks to Ashley Charbonneau, Paula Pelucci, Lori Kemp, and Chaya for their contributions to this presentation. So what is it that we're hoping to spend the next 2 hours or so talking a bit about? So I'm going to start with a bit of a brief background on the Headz ED. Talk a bit about how the Headz ED has been used in other settings and primarily in primary care, and I'll talk a bit about our primary care pathways. Ashley will then talk a little bit about the progress update on a scoping review of the mental health and development and screening tools for children 6 years of age and younger. Joel and myself will then spend some time talking about how we've adapted the Headz ED for children under 6 and the preliminary results of an implementation study that we've done with the folks from Children First. And hopefully we'll have some time at the end to bring it all together to wrap up and talk about how the Headz ED can be used within a primary care setting and to help primary care providers support mental health of infants and young children. So, big step back. I'm going to talk about the Headz ED, and it's I call it the subtitle is a child and youth mental health triage tool. And you may ask, why are you using triage? Because triage is a medical term, and mostly because the tool was originally developed as a screening tool to be used in a medical setting, essentially the ED being the emergency department. The actual tool itself, in terms of development and implementation, we've been on this for about 10 years now, and maybe a bit longer. And the number of people have contributed to the development of the tool, and you can see a whole list of colleagues here, and some of these names might be familiar to some of you folks in the community. And not only do we have lots of individuals who have contributed to the development of the tool and the validation of the tool, but we've also been really fortunate to have a number of providers, both public and private, that have supported the work we're doing. And I do like to declare that there's no conflict of interest. The tool and the work that we're doing is publicly available, and there is no financial gain on my end or our group's end in terms of any of the use of the instrument or the publications or the data. So where did this all begin? Well, it all began in the emergency department. And why there? Lots of kids come to the emergency department, and there was really no standard of practice or tool that would help in the assessment or disposition of mental health concerns within the emergency department, despite the fact that a lot of the professional associations and committees really advocated for the development and implementation of standardized clinical tools as a way of facilitating the assessment and identification of mental illnesses and concerns. The research that was done basically up until the last number of years showed that only about 10% of emergency department physicians used any evidence-based screening methods to look at mental health concerns. And when we first started doing this work, and even though it's kind of plateaued in the last couple of years, we saw an overwhelming increase of mental health and addiction concerns presenting to the emergency department, despite limited resources, both in terms of assessment and services to meet our children's and adolescents' mental health needs. So, if you're going to develop a tool and you want it to be a good tool or have some accuracy, there's different guidelines or criteria that you can use. These are the criteria that were established years ago by the WHO and still very much applied. And so essentially, a good tool or good screening tool should, one, be able to detect those with the disease. That kind of is self-explanatory. It should also be safe and acceptable, so it shouldn't cause a tremendous amount of discomfort. It should be reasonable in cost. So if you're going to be doing a lot of screening, you want a tool that is, it's very, very inexpensive. It has to lead to a demonstrated improved health outcome. So it's pointless to do a screening test if you can't then take those results and actually implement and improve individuals' health. And lastly, we sometimes forget is that you need to have actually services available should you have positive results. So I think, it seems, without saying that, what's the point of screening if there's then nothing that we could do with those results? So that's the WHO's criteria. But I think when we looked at the WHO criteria and we look around in terms of what we want in a screening tool, particularly when we were looking at an emergency department perspective, and I think it doesn't really matter the setting, whether it's an emergency department or a community mental health agency or another organization. Really what you want is that the assessment has to make sense in that environment, but it also has to be meaningful to the mental health professionals in both the hospitals and the community. So it has to really be able to have meaning across all providers. And so meaning for us is about responsiveness. So if you're going to screen, you want the responsiveness of to meet the mental health needs first at the local to hospital level. So for us, it was about the emergency department. So in other words, you wanted to be able to identify whether or not an adolescent or a child needs an admission, or whether they need it, whether they need, a crisis intervention, or whether some other type of intervention. But you also want a tool that's responsive to the mental health needs at the community level. So in other words, you want a tool that regardless if it's a hospital or community, that tool is used in both settings, and that it should be able to access the tool, should be able to at least provide some direction in terms of the community-based treatments. And finally, and I think from as a researcher, it has to be responsive to the mental health needs at a societal level. And what does that mean? It means that we should be able to take that tool and be able to integrate it within a clinical pathway that truly integrates the assessment, hospital or tertiary-based services with more community-based services. And the other important part about this final responsiveness criteria is that at a societal level, it shouldn't matter whether or not the child presents to the emergency department, for example, in Ottawa or Thunder Bay or Sault Ste. Marie or Toronto. That pathway should be the same. However, when you ask physicians or clinicians what they expect in a triage or screening tool, they make it very, very clear. Your tool has to be very, very brief. It's got to be easy to complete. It's got to be simple to score. It has to make clinical sense. It has to have really good psychometric properties, both in terms of validity and reliability. And at the end of the day, most of us want a clinical tool that helps guide our clinical decisions, not just in assessment, but also in terms of treatment recommendations. So it's a pretty tall order when you're trying to develop a quick, easy to do screening tool. So rather than trying to invent our own or create our own, we decided to take a look what was available already in the literature. And the Headz is a mnemonic that is widely used in the U.S., particularly in a number of U.S. medical outpatient clinics. It was developed in the early 70s as a way of conducting a psychosocial interview with young people. The Headz is taught by a number of various organizations and is part of the residency programs in a lot of medical schools. And over time, it's changed so that the mnemonic's gone from the Headz to the Headz to the Headz, with different S's meaning different things. So we had this tool or this mnemonic called the Headz. And at the time that we were developing the Headz ED, Dr. John Lyons was our endowed chair at CHEO, and folks may know Dr. Lyons' work on the CANS. And what really made the CANS interesting is that the CANS is a communometric measure. And I'll talk a little bit about what that means in a minute, but essentially we wanted to look at, can we take the Headz and map it onto something like the CANS or that model of a communometric assessment, and see if it would make some clinical and psychometric sense. So that led to the development of the Headz ED tool. And subsequently, we also have a number of websites associated with the tool that also facilitate the uptake of the measure. So this is what the Headz ED looks like. It's essentially one page. On the left are the different domains. So H is home, education and employment, activities and peers, drug and alcohol, suicidality, emotions, thoughts, and behavioral disturbances. And lastly, discharging current resources. And then at the top are the different levels of needs within each of those domains in terms of what is the severity of those needs and what is the need to act on those severities. So 0 meaning that there's no action needed, 1 meaning that there is some action needed, but it doesn't have to be done immediately, or there's mild to moderate functional impairment. And 2 is that there's a need, and the need requires some immediate action, and that the impairment ranges from moderate to severe. So if you take a look at home, for example, home, 0 would be a supportive environment. 1 would be that there's conflict, but they're manageable. And 2 would mean that the home situation it's chaotic and there's lots of dysfunction, and so on. There's no formal administration instructions or probing questions, although within each of those domains, you saw that there are some questions. The Headz ED tool does require, assume that there is a basic knowledge of child and youth mental health. So most of the folks that were completing it have some clinical background. And for the Headz ED, originally developed for physicians and emergency departments who see lots of young people come through the front doors. Essentially what you do is you add the 0s, the 1, and the 2s, and you get a total score. It's pretty simple. Don't need a calculator for it. A score of 8 or above, or a score of 2 on suicidality was the trigger for recommending a specialized mental health consultation. So if you work in the emergency department, essentially that's when you would ask for a psychiatric consult or a crisis worker consult to do a more in-depth assessment. And typically any score of 2 on any item does indicate emergent need for follow-up. There's been a number of studies that we've done that support the psychometric and communicatric evaluation of the tool. I'm going to walk through a couple of these just to sort of show you how we went about to validate the tool. So the first one was looking at the inter-rater reliability and the validity of the instrument. And what we did was, this is way back in 2011, we had within a CHEO at the Children's Hospital here in Ottawa, we had about 300 kids that came through our emergency department that were seen by the crisis worker. And the crisis worker completed the Headz ED. They also completed the CANS, which is the longer version of this is the longer version of the tool developed by Dr. Lyons. And finally, the youth also completed the Children's Depression Inventory. 149 of the 300 kids roughly went on to get a psychiatric evaluation, and 66 of those youth were admitted. And what did we find? Well, the first thing we found is if you take a look at the far right, and those are the correlation coefficients between the Headz ED scores corresponding to the CANS, which takes about 45 minutes to complete for the whole measure, you can see that our Headz ED scores correlated well with the corresponding items on the CANS. And if you take a look at the correlation between the Headz ED items and the corresponding items on the Children's Depression Inventory, and again, if you look at the far right and you see the correlation coefficients, they were all significant between what the youth and the children were self-reporting versus what the crisis worker had reported. So we ran some predictability analysis, and essentially this is where we found the score of 8 or suicidality of 2. And if we use that criteria or those cutoff, we had a sensitivity and a specificity of 82% or 87% between the consultation and the hospital admission, which was done independently by the psychiatrist. So what does that mean? If there were roughly 66 children that were admitted to hospital, and those evaluations to admit to hospitals were done by a psychiatrist or psychiatric residents. They were done independently of the Headz ED scores. They weren't aware of what the crisis workers had rated, and you found that the sensitivity and specificity was quite high in terms of what the decision was that the psychiatrist made compared to what the decision was based on the Headz ED. So really good sensitivity and specificity as a screening tool. So what about ED physicians? Because that last study was based on crisis workers. And this was a study that was done in 2014. And essentially, again, done here at the Children's Hospital at CHEO. We had roughly, we looked at roughly a 6-month period, and we had roughly 2,700 children and youth who came to our emergency department. We only looked at kids between the ages of 12 to 18, and we only limited to kids presenting during the day, and essentially shutting recruitment at about 8 o'clock at night. So we had about 640 youth who participated in this validation study. So what did we do? All we did was we took that one-page Headz ED that you saw earlier on, and we affixed it to the patient's chart by the registration clerk. And so back then we were still using a paper version of the chart. So that's all they did was they included the Headz ED tool on the chart, and we asked the physician to go ahead, do their typical assessment, and if they would also complete the Headz ED tool as part of their assessment. At the same time, there were roughly 40% of the kids were also seen by our ED crisis worker, who then went on and did their typical assessment. And the ED crisis workers did their assessment independent of what the pediatric emergency physician's assessment was, and they also completed the Headz ED, so they were aware of what each other's ratings were. And what did we found? We found that the physician's mean Headz ED score was significantly higher for those who received the consult to the ED crisis worker than those that did not. So in other words, the physicians decided to refer the child to the crisis worker for an ED for a more in-depth assessment only after their Headz ED scores were greater than those that they didn't ask for a consultation. What was also really interesting was that the physician's mean Headz ED scores for those admitted to the hospital was significantly higher for those that were discharged back to the community. And again, the admission here was done by the psychiatric resident or the psychiatrist who did not know what the physician's ratings on the Headz ED scores were. So you saw this really nice predictive finding where the higher the score was leading to more intensive services, a lower score was leading to lower services or discharge back to the community. And this is a graph that basically shows you what the scores would look like. So at the bottom axis, you see the scores going from 0 to 14, and then the left axis is the number of the percentage of clients or patients. The higher the score, the more likely that you are going to get a consultation, and the higher the score, so 11, 12, 13, 14, the more likely you're going to be admitted. I always show this graph because I want everyone, I want people to take a look at the fact that you could still have children who were asked for a consultation or were asked or may have been admitted with scores under 8, because no tool, as we know, replaces our own clinical judgments. At the end of the day, any tool that we use helps guide what we're going to decide, but it shouldn't replace our own decisions in terms of what's the best possible care. If you recall, I also mentioned earlier when I was talking about the results that not only did the pediatric emergency physician complete the Headz ED, we also asked the crisis worker in the emergency department to complete the Headz ED, and the crisis worker were unaware of the results of the physician's ratings on the Headz ED, so they were done independently. Our crisis workers at CHEO or MSW trained clinicians, and they'll spend, a significant amount of time, doing their assessments. What's really interesting here, if you take a look at the ICC, which is the interclass correlation coefficients, and these are the correlations between the ratings of the physicians compared to the ratings of the crisis workers. And again, the physicians completed these with no training, although they have they do have some background in children and youth mental health. And you can see that the correlations are all significant. So the physicians' ratings on the Headz ED were very comparable to the crisis workers' ratings, which is great, which is what you want to be able to see. And just briefly, I'll talk about another study that was done by Sharon Clark at the IWK Health Center. We were involved a bit in this particular project, and they wanted to look at, Sharon had asked us when she had heard about the Headz ED, whether or not they could use the tool as a screening tool as part of their centralized referral intake to their children's hospital. And so IWK services the province. And so for tertiary services, so they get lots of referrals, and then they were asking, can our intake workers use the tool, and can it be used as a way of identifying the type of services that kids might benefit from? That study looked at roughly 674 kids. I want to point out that even though, you know, there was no under 6 version of the tool, they still use the tool for kids under the age of, you know, they're 5 and younger, right? So there were roughly 60 of the kids that were included in their sample as an FYI. And the next slide shows you the relationship between the Headz ED scores and what the service recommended for the family. So if you look at exit, so the mean score in the Headz ED for roughly the 108 children who were discharged was roughly 2.6. Kids that were recommended for a E-based and Strongest Family, some of you folks may be familiar with the Strongest Family program, was 3.5. And the more intensive the services, whether it was a regular appointment or a priority appointment or a concurrent appointment for kids who had both, a dual and a mental health concern, you can see that the scores increased from 4 to 6 to almost 7. So again, the intake workers' ratings on the Headz ED tool corresponded well with the types of services that were being recommended for for the child or the youth. I mentioned earlier that the tool is not only used as a screening tool, but also has something that we call the communometric value. And this is the, I think, the real tremendous value of the tool and the work that John Lyons, has invested years and years and years on. So the idea is that the tool should not only help us determine the need, but ideally should also help guide what services might help meet those needs. And so this is where we've developed a general website that's used for the tool itself and for some training called the headzed.com. But we also have developed private websites within each of the communities or each of the regions, which then allows the services and the needs to be linked. And I'll just quickly show you so essentially you would go online and the front page would show up. It would ask you to include your demographic in the catchment area. There's some videos there that show you how to actually, if you wanted to know a little bit more in terms of how to use the Headz ED tool. The tool pops up, and if you hit sample questions, it shows you different questions you can ask. So if you hit home, the pop-up would be, how does your family get along with each other? You can ask about issues about child protection and family violence and so on. On the far right, you can hit the notes button and you can type in some notes. The scores are automatically calculated. And then depending on the score, it will tell you whether or not it requires a more intensive mental health consultation. And then what happens is that depending on the catchment and what was identified as a need, so for example, in this slide, we're using the Cornwall catchment area, and home was identified as a concern, so it automatically pulls up the Cornwall Community Hospital Child and Youth Mental Health Services. It tells you what the ages it serves, the contact information, and it describes what the eligibility is and what services are and what services aren't provided, and what other services are available should the services you're looking for within the home not meet the eligibility. It also includes safety instructions for the youth that may present with more significant concerns. You can then print and email the results for the client's file. And you can also just go back, and then you can also print and email the client the client profile to the family as well, so that they can take that away with them and not only the Headz ED profile but also the recommended resources. The one thing that we, when we developed the tool, the one thing that we did was we copyrighted with something called Creative Commons, which essentially allows the tool to have some intellectual copyright protection, but there's no restriction on the uptake of the tool. And essentially, our decision to go with a Creative Commons was that we felt that if we put any restrictions at all in terms of the uptake of the tool, then we were worried that people would simply not use the tool. Even contacting is an additional barrier, and we wanted to really make it as barrier-free as possible. The problem with that is that we really don't know who uses the tool, and so it was really how do you get the news out? And so we hear about where the tool is being used. We also get lots of emails and requests about the tool, and I'll give you some examples of where the tool is being used. So provincially, it's part of the Ontario's clinical pathway for children and youth with mental health conditions who present to the emergency department. This was a toolkit that was developed by the Provincial Council for Maternal and Child Health and by Mona Jabor and Jeffrey Hawkins. The pathway has been implemented in a number of hospitals, and there's some ongoing work in this area. And so it's part of our provincial pathway. Just recently, there's no slide here, but just recently we found out that the folks down south of the border has also recommended the Headz ED within their emergency department clinical pathway, and is being implemented in a number of American communities as well. This is what the pathway looks like in our emergency department. I show you the slide only as information, and you can see towards the bottom of the slide, the yellow box that says Headz ED, and that's usually when it's completed. So just before decisions are made in terms of whether the child should be admitted, or whether it should be community mental health services, or whether there should be follow-up with primary care. As I mentioned earlier, we have, there's been lots of uptake of the tool in the US as well. Here, this illustrates some of the work that we published in the US. In Ottawa, the Headz ED tool is also used in our school boards, and it's a way of helping to link our school board's mental health crisis services with our emergency department mental health crisis services. So the mental health clinician at the school would complete the Headz ED tool, and if the child was being sent to the emergency department, they would connect with our emergency department crisis worker, and they would chat about the scores on the Headz ED tool and determine whether or not the child should come to the emergency or not. There's nothing worse than sending the child to the emergency department, spending 6-7 hours, and only to be told there's nothing we can do and send you back home, or send you to your family physician, back to your primary care. And this is pretty discouraging for families. The tool is also used in Toronto as part of the mental health Toronto centralized intake. I know that, and I believe the name now has been changed, but if you call into their centralized intake, the intake worker completes the Headz ED tool as part of their overall screener. And lastly, the tool has also been now integrated within our electronic health records. So for instance, at CHEO, we use Epic, and several other hospitals also use Epic. And so the Headz ED tool is part of that electronic health record, so that the physician or the intake worker would then complete the tool and then be part of the child's overall health record. So that's the tool. I'm going to just take a breath right now and see if there are any questions. Chai, if there's anything that people might want to ask, and then I'll move on to.
We have one new question that's come in. When on the website and using the tool, will it recognize all areas of Canada or Ontario? We're recommending other services within the area that could be the next step. But I think, Mario, the expectation is that clinicians using the tool should know what services are available in their communities. Would that be what you would be expecting, or is the tool tracking what's out there?
The way it normally would work within the communities is that the clinician should be aware of the tool, the services that are available in that community, and then the tool would be used as a way of helping to facilitate that conversation between the domain and the services that are available. In our web-based version, what we do is essentially, let's take, for example, in Ontario, if there's a lead agency that wants to use the tool, we we freely provide the instrument with them, to them. And I'll show you this in the next slides, where I talk a bit about the primary care pathways. And we work with ementalhealth.ca to help link the services that are identified as those services within each of those domains, and create that website for the community, and then give the website over to the community for them to be the administrator, so that they then manage it.
Okay. And then another question, though designed as a screening instrument, has it been used or explored as an outcome measure?
We haven't used it as an outcome measure. We really, it has a very specific purpose, and so we try to really maintain the integrity of the tool for that purpose. I think there's lots of other really good outcome tools, and there's lots of really good, more in-depth assessment tools. So from our perspective, when we originally started the development of the tool, is really to help physicians and then become, and more recently in the last little bit, also intake folks, to be able to quickly screen need versus outcome. So we tended to stay away from looking at it as an outcome. And we also chose deliberately not to have it done as a self-report or for youth and young adults, or as a parent report, because we wanted this to be a real tool used by clinicians and providers, and not as a self-report. Again, there's lots of other screening tools that are available as self-reports and as parent reports that we think serve, are much better than our tool and serve that particular purpose. So we really, again, wanted to maintain the integrity of what the tool was developed to do.
Great. Okay, I think that's it, Mario. So
Great.
I think we
so
can
I'll move on to the second part of the next part of the presentation, which is really to talk now about an area where the tool's being used, and I think there's some really good applicability, or maybe this is an exemplar in terms of how to develop primary pathways for our children under the age of 6. So I'll talk a little bit about the primary care pathways that we've been working at the center with a number of our communities in the province, where we're trying to create connections between primary care and our community-based child and youth mental health services. This is our team, and I just wanted to go to the very bottom of the page and to thank Chrissy, who was working with us as our senior data analyst, who's no longer at the center, but she had also contributed to the work, and to Pranima Sundar, who's our executive director at the center, who's been very involved in our primary care pathway. So it's way of background. And again, I think, even though when we were looking at the primary pathways literature, and we, essentially looking at kids over the age of 6, and Ashley will talk to this a little bit more in the next little bit, but I think some of the background information is the same regardless of the child's age. It doesn't matter if it's under 6 or school age or adolescent or young adults. 62% of families, we find, first attempt to access mental health care through their family physician or through their primary care, provider. Most primary care folks report feeling ill-equipped to deal with mental health concerns. At the same time, we all recognize that our community-based mental health services have long wait lists, don't have sufficient funding, and there's which limits a lot of access. In Ontario, we are going through lots and lots of primary care reform, and a huge one is that child and youth mental health, moving to the Ministry of Health, so it was a major reform, as well as our Ontario health teams, which basically talk a bit about, how do you develop collaborative partnerships and as a way of potentially improving access to care, quality of care, and improving outcomes. So the timing of our primary care pathway, seemed pretty, it was bang on. It's still a work in progress. In 2017, we published a policy paper at the Ontario Centre of Excellence, and that if you go to our website, this policy paper on primary care, as well as a number of other policy papers, are available there. They have tremendous relevant information and wonderful background. And that policy ready paper that we wrote and generated 8 recommendations in terms of how to improve the interactions between primary care and community-based mental health services. In 2018, we did a pilot of 3 of the recommendations from the policy ready paper. So the most interesting thing here is that we often write these policy papers, write these systematic reviews and these scoping reviews, and all they do is, look great. They're great for CVs, but nothing much happens. But what we decided to do this time is that we actually took a look at some of those recommendations from the policy paper and say, can we pilot to see whether they can be implemented, and can we get some sense of the feasibility of doing that implementation? And so we worked with 2 communities to assess feasibility. And essentially what we did was a few things. One, we created some structures or practices that would support inter-provider communication within each of the communities. So creating roundtables of the various providers. We then developed some clinical pathways that went from primary care to community-based mental health services. And I should say at this point that the pathways that we developed were also co-developed with youth and with families, so that they took a look at the pathways, they looked to see whether or not it made sense, and we refined them based on some feedback. And then we also integrated the Headz ED tool within primary care and within the pathway. And the 2 agencies that worked with us in the feasibility were both the Goma Family Services in Sault Ste. Marie and East Metro Youth Services in Toronto. Last year, in 2019, we took some of the initial results from our feasibility study, which basically said, yes, you can create these roundtables. Yes, you can develop pathways, and yes, you can validate the tools. And yes, we did a tiny, implementation, and it seemed to work, although there were clearly some glitches, which is the whole point behind the feasibility. And we said, can we take those findings and take the lessons learned and see whether or not we can do a larger demonstration trial? So this began in 2019, and we went from the original 2 sites to 6 partner sites. And it's a 2-year quality improvement initiative. As I mentioned, within each of the sites, we bring together primary care and our community mental health site partners. We want to evaluate whether the model that's being implemented is the one that we thought we should be implementing. We also, in the primary care demonstration study, we're getting the experiences, feedback on the experiences from children, youth, and family members, as well as the experiences from our healthcare providers with the pathway. The 6 trial sites include Stormont, Dundas, and Glengarry, Hastings, Prince Edward County, Oxford, Elgin, Sault Ste. Marie, Windsor, Essex, and Toronto. I show this slide only to kind of give you a sense of the types of activities and the phases that are involved in being able to run a trial of this, to this extent. And you can see that there's multiple phases, right from pre-implementation to the research proposal to preparation, and then subsequently implementation, and finally post-implementation. And then within each of those, there's multiple key activities that need to be done. But the most important thing is really the pathway, because that's what it really starts with. And I'm going to show you the pathway. This is the Goma Care pathway, and it looks really complicated, but there's really only essentially, 4 colors. The first color box is the blue, and the blue is where the child, walks with their family into the primary care's office, presenting with a mental health concern. And from there, they, depending on the level of concern, the physician or the primary care, could be a nurse practitioner. He or she would then suggest, based on the level of acuity and need, would either suggest, sending the child, recommending the child access, the local emergency department or access a crisis, unit, or would send them to the community. So the red is more crisis, and in that green looking color box and arrow is the more community-based. That's based, part of that decision is based on the Headz ED score. So if you look at the top, it says if the score is greater than 8 or suicidality is 2, then send them to urgent or immediate care. Or if they're less than that, then send them to the the community. And in the community, then we'll triage the level of care. And then at the bottom, you see the arrow going back up to primary care. So there are 3 key parts to this pathway. 1, there's the Headz ED, which is the triage screening tool. 2, that there's a common referral or communication form or path that links primary care to community-based mental health services, and which then relinks back to primary care. And 3, that there should be a rapid response so that primary care is informed of the disposition of the referral. The most frustrating part of care the most frustrating response I hear from physicians and other folks in primary care, and I'm sure some of you folks have heard similarly, is that they'll refer a patient to one of our agencies, and then they don't hear anything back, and they don't know what's happening with the child, and where is the child getting care, when's the care happening, and so on. So them being informed in terms of how we're dealing with our client helps them in terms of continuing support to provide that continuing support in the interim should the child be on the wait list. So key element 1 is the Headz ED tool. The key element 2 of the pathway is the common referral or communication form, and this is what it looks like. It's basically in the pathway, the physician or the primary care office completes this 1 pager, and this is the referral form. The blue part is part A. And all it says is, what was the child score in the Headz ED? What's the presenting clinical background? And have you gone ahead and and identify the mental health agency that's going to do the follow-up? So in the SUE, it would be Algoma Family Services. There's also a consent that they get. That's a verbal consent that gets checked off within the Headz ED. So it shows that, yep, I've talked to my patient and they know that this referral is being sent to you. So we're not asking for a ton of information for the physician to complete, just the basic referral. They then take this information, send it to the community agency. And then the third part is the primary care physician is informed of the disposition of the referral. So the community agency then takes that same form that the primary care provider had complete. Now they complete the bottom of the form. And so that could be the agency, or it could be the lead agency. It could be one of the, more often than not, it's one of the core service agencies. And essentially they check off what the outcome of the referral was, whether intake was scheduled and so on. And then if they know the anticipated wait time for services, and then they fax it back or email it back through a secure network to the family physician or the primary care provider. Part of our primary care pathway also involves an evaluation piece. So at approximately 1 month after completion of the referral, we go back and check in with the families to access, to get a sense of what their experience with the referral process was, whether their services were accessed, and what their satisfaction was with the wait times and access. Essentially, we're not asking about, were you happy with the services you received? We're really evaluating the pathway. So in other words, from the moment that you went to see your family physician to the moment that you were referred to services, what was it like to go through that experience? And so here are some of the things that we're looking at in terms of our evaluation. From describing the profile of the children and youth who are presenting, we're also looking at the uptake of the pathway using the Headz ED, looking at providers' views and our families' views and experiences with the tool. So where are we at with the with our implementation is essentially, so this is the various sites, whether we've done community meetings and site visits, whether we've done training. We're doing a little bit of the Headz ED training with our physicians and what the launch dates were. So essentially a lot of the, some of the initial sites had been launched. We started collecting data. Toronto, we've been working closely, and we're going to be working with the folks at Scope to do an implementation there. And we almost got going, but we had to put that on hold for a little bit, and I'll explain in a minute. And just to share with you some of the preliminary data. So this was data that was collected pre-pandemic. And so at the time, so this was a couple months into the implementation. We had, the numbers actually a little larger, a little bigger than they are now, but roughly 73 kids have gone through the pathway. There was a 99% completion of the referrals of the Headz ED by primary care folks, so physicians completed the tool. The mean score was 5.6 on the tool, and if you take a look at the right, and you look at that distribution, it kind of looks like a typical normal distribution. So there are some, children and youth at the two tails with either very mild, concerns, or at the far right with more significant concerns, and a lot of the children and youth clustering in the middle. Roughly 20% had a score of greater than 8, so 1 out of 5 children needing immediate services, kind of what we would suspect. We asked for gender, not just sex, and we found no gender differences in the median Headz ED scores. Roughly a score of 6 for males and a score of 5 for females in terms of sex. And 71% of kids, so down below the items needing immediate action, 71% of the children and youth weren't accessing any services at the time of their presentation to their family physician. So in other words, this goes back to the same data that we found in the evidence that talks about roughly 60 to 70% of children and youth access mental health services for the first time through their family physician. So it's exactly what we found, and even in our small sample of 73. 31% of them presented with significant or a score of 2 in terms of challenges with activities and peers, and 30% presented with a score of 2 needing immediate action for emotions, behaviors, and thought disturbances. And if you take a look at what most kids present with, it tended to be anxiety and depression, followed by ADHD and attentional issues, and so on, down to suicidal ideation. Not surprising, females do present with more anxiety and depression than males. So this is the really interesting part as well for us, is the Part B completion of the pathway, which is, the Part A was the primary care, completion of that simple referral form, and Part B was what happened with that form after the referral to the community agency. And we had 93% completion of Part B, so that's great. And if you take a look at the outcomes on the pathway and what happened with Part B, first contact with clients was usually done within 4 days. Part B was completed by the agency within roughly 8 days, and faxed back to the primary care providers within 12 days on average. So there was really quick. So the pathway seemed to improve the efficiency that of the referral. And the really nice thing was that the physicians and the primary care centers and providers were informed in terms of what services or where the child was in terms of their accessing services. And if you take a look at what was being scheduled, 33% of the clients that were referred had an intake scheduled, 25% actually had the intake was completed, 22% services were booked, and then there was a small percentage of children who either could not be reached, declined services, or ended up being diverted to a different service. So essentially what we found was that there was a high uptake of the Headz ED tool. There was a high uptake of the pathway, and there was really good completion of the very simple referral form, both at time A and time B. The client profile and the referral patterns were kind of what you would expect given the general evidence in terms of children and youth mental health, and that there was a really nice timely response from the community mental health agency or core service provider back to primary care, which is great. And then came the pandemic and COVID-19. So we've been essentially on hold since March, when everything else shut down. And what was really interesting for us, and this is something that I think really it highlights the challenges in terms of integration of care. Here we worked really hard to build this pathway to facilitate communication and so on. And then suddenly when the pandemic hit and primary care folks moved to telephone-based calls, and some of us, in terms of services, had to move to virtual care, we stopped getting referrals. And I think most agencies saw a significant drop in the initial referral rates, and there was a real, again, some real concerns in terms of the refragmentation of services and the lack of integration. So that's something that I know lots of folks are looking at in terms of how COVID-19 has impacted children and youth and families' mental health, but also not just their mental health, but also in terms of accessing the services. So we're slowly going back online. We're now about 4 months behind, but I think the lesson learned for us is, how do you then create a pathway that is also responsive to unseen, or unpredicted events, right? And how do we now change a pathway that also has a virtual component to it, so that it shouldn't affect the integration of services or that referral of care from the various providers. So just a deep breath. So what's the summary to date on the last two sections of the presentation? One was that the psychometric properties of the Headz ED tool seem to be solid, particularly as a quick screener. Despite the little publicity, the tool has had really good uptake across a variety of settings. There's some strong preliminary evidence that shows it can be used in a clinical service or pathway that integrates primary care services with our community-based child and youth services. But even though the tool was used with the folks at IWK under 6, we felt that, it really wasn't meant to be used with that population. And is there something that we could do for children under the age of 6? So I'm going to stop here and see, before we move to the next section, if there's any questions or comments that.
Yeah, Mario, we have a couple of questions coming in. One is, can the tool be completed by a caregiver?
So the tool is not a caregiver, meaning a family member, like a parent. It's not intended to be used for that purpose. It really was developed to be used as a provider or a clinician tool. So I think there are other screening tools that could be used. It wasn't developed for that purpose. I think there's a real opportunity to see whether or not it can be used for that purpose. We just haven't, that wasn't its intent.
No problem. And are nurses using the tool at all?
Yeah, a lot, tools, the nurses are using the tool in primary care settings, in our emergency departments, so absolutely.
Great. And someone's asked about how it's being used, how it's being spread across the province, like through the lead agencies. And I just want to confirm that the chart that you showed, your sites, are those the only places that are using the tool? Because we also have a question asking about, is the pathway referral form available as a PDF even now? So I guess people are just wondering, what can I get now?
So,
if I want to use it.
So I think the tool, in terms of, who is using the tool, there are a number, again, partly, we don't really know absolutely everyone who's using the tool, because it was a Creative Commons copyright, and it's freely available. They don't even have to contact us to use the tool. We presented the tool to the consortium, so they're very familiar with it. The folks in the various lead agencies, most are familiar with the tool. We've also starting to work with CMHO in terms of putting the tool, making the tool more available to other folks. We've also, folks in mental health, we presented to the various mental health leads of the ministry as well, so they're familiar with the tool. And a lot of this is really about, it's like there hasn't been any campaign to get the tool out, but I know there's lots of other folks that are using it. It's being used in Ottawa. It's now going to be used as part of our health team. So I wish I could put up a slide that said, here are all the people in Ontario using the tool, but that slide doesn't exist.
So I guess
anything, and then regarding the question regarding the pathway and the form that we use, certainly folks can email me, and I'd be more than glad to share any information that we have if it'll facilitate the work that they're using, and be more than glad to do that.
And I think that the real issue is, can people access this though? Like if they want to use it, I recognize you're not tracking, but if people do want to use the tool, can they download it from the site? Are they able to access it through the center?
So the tool can be accessed through the website. They can email me. You can probably just Google Headz ED and it'll come up.
Okay.
I just noticed at the very end, Janet McQuarrie just posted that the Headz ED is being used in their walk-in clinics, and they have a partnership for 30 years. So thank you,
Great.
Janet. We know that it's being used. For example, we've started working with some folks in Italy. They've translated into Italian, and now they're using it in a couple of the in the pediatric hospitals in northern Italy. So again, that was just them reaching out to us, and it's really funny there is that they're using the Headz ED, but there's home is not the same thing in Italian. It's familia, but they still call it the Headz ED tool. So that's interesting. So I think I'm going to move on, and I'm going to pass it. I'll take a water break here, and I'm going to pass it on to Ashley to talk a little bit about the children under 6 and some of the work that we're doing with that population and the tool. So Ashley, I'm gonna.
Great, and Mario, you'll still be available to switch the slides for me?
Yeah, I'm right. Yeah, I'm right here. So there you go.
Great. Okay. Good morning, everyone. Thank you for being here and your attention so far. I think the front end of this presentation was really to explain all the foundational work that has led us to the point now, like Mario was saying, that the under 6 population is very special and unique. And so we've come to realize that and have had a lot of stakeholders express interest in a tool that can be used in this population. And it sounds like the population that you're familiar with and working with. So the remainder of the presentation today will focus on this special age group, but the previous work was necessary in order to come to the point that we're at right now. So the project that we're working on in parallel with some of this pathways work and testing out the Headz ED is actually taking a look at the literature and what's already out there in terms of screening tools that can be used by a healthcare professional to take a look at the mental health and the development of children under 6 in a clinical setting. So as someone had mentioned in the question box earlier, there are already screening tools and assessments that do exist. For example, the ASQ and other things that are commonly used in some of the service settings, and Joel will be speaking to a little bit about that as well. But we wanted to get a sense of the lay of the land and what the landscape looks like. So one of the methods or means to do that is what's called a scoping review. So we have a team here of clinical researchers together with a research librarian who's helping us take a look at the literature right now through a scoping review. Next, please, Mariel. So based on the audience today, I would assume that you're a bit familiar with the literature and the background in terms of what a lot of the kiddos under 6 look like and the prevalence of the issues that they may be presenting with to some of your agencies. But just as a very brief overview, it's often thought that 1 in 4, 1 in 5 children under 6 actually are quite at risk for some sort of developmental or mental health concern very early on. And it's important to identify these possible delays or concerns early, of course. And we want to then ensure that young children get the services and supports they need as early as possible. And we really want to enhance that developmental support. Screening is, of course, a way to do this. And we're able to administer a quick assessment that yields a simple snapshot in time of how the child is developing, what their health is, and this is where we can identify certain domains or areas that may require further follow-up or further assessment with, say, a more comprehensive tool. So when we talk about screening, we're not talking about anything that's diagnostic or definitive. We're talking about something that maybe gives us a strong hunch one way or another about what this child might need. So in particular, based on the work that we're interested in, we know that primary care providers play an extremely important role in addressing the mental health needs of children because parents tend to develop long-standing relationships with their family physicians in that they bring their children there often. There's a lot of routine visits, and they tend to bring their child there at multiple time points throughout the lifespan. So primary care is really this unique opportunity for healthcare providers to get a sense of children and how they're functioning and developing, and also provides an opportunity to intervene. So we really want to equip primary care providers with the tools or the process to better identify some of the youth who have concerns early on. But we often hear from primary care providers that they're kind of lacking the training or the confidence in order to successfully kind of identify or detect this youth, or sorry, these children early on. So we want to make it a bit easier for them. As well as for any of us who visited a healthcare professional, we know that usually those visits are really quick. So we have to be mindful of the time constraints. So something like a screening tool that's relatively brief to administer, we want to be able to identify what's already out there and doesn't require a lot of knowledge or training to administer and score. And again, for the reasons we discussed earlier, earlier detection and intervention is important to hopefully reduce some of the future impairment that could come from a delay in treatment. Next slide, please, Mariel. So one great way to get now a snapshot of the literature and see what screening tools already exist is to conduct what's called a scoping review. A scoping review is a type of knowledge synthesis, so a combination of evidence or literature that follows a systematic approach. And this is a way, again, to map out the current evidence base and the landscape of what's already published and what's already available. Now, a scoping review is similar to a systematic review in that both are systematic and have a strict procedure that we follow. However, the scoping review is different because it focuses more on describing what's out there versus comparing tools in terms of their effectiveness. So a scoping review is used when we want to answer the question, what is known about a certain topic? So in particular, the research question we have for the scoping review is we're interested in identifying and describing existing multidimensional mental health and developmental screening tools that are administered by a healthcare professional for children in our age range, so those under 6 years. So an overview of the methods or how we would go about conducting a scoping review is there's these reporting guidelines that exist called the PRISMA guidelines, and this helps make sure that we're rigorous in every step. So the first step, once you have your research question, is to take a look at all the major databases out there and see which literature is out there. So this complex search strategy involves the use of a research librarian who takes us through this, make sure we're identifying all relevant literature. And then with two reviewers, we go through and identify which literature is relevant to answer our research question. Next slide, please, Muriel. Now, when we access all of the literature that's available, of course, we have to decide what we're going to include and exclude. So for the purposes of this review, we're looking at studies available in English, again, those that are directed at children in our age range. We want a screening tool to be talked about in the literature either as being under development or being tested or validated or used. Again, we're only looking at tools that are administered by a health professional, so a physician, pediatrician, nurse practitioner. We're not looking at those that are administered only by parent or teacher report or something like that. And we're interested in multidimensional tools, which means they need to be looking at least 2 or more domains of mental health or developmental functioning. And then we're looking at studies that have already been published and are validated to some extent based on a peer review process. Next, please, Miriam. So this is an overview of what essentially the literature funneling process looks like. So with our research librarian, we identified well over 3,000 different articles in the literature that may be pertinent, and using those 2 independent reviewers, we have to go through and apply that inclusion criteria that I just mentioned to isolate and find the exact articles of interest. So through a 2-stage review process, we're ending up with 24 articles now that will undergo data extraction. We'll actually take a look at those 24 articles to see what they have to say about our research question. So, and Mary, you can hit next. So in order to make this process really rigorous, because we have 2 reviewers, we need to look at inter-rater reliability. So for example, myself and we have a research assistant on the team. How similar are our decisions on whether or not we're going to include an article in our study? And I have on the side here our statistics for what that inter-rater reliability is, and it's well over the 90%, which indicates that we have substantial or near perfect agreement in our decisions. So this is something important when we go to report our findings, but not necessarily important to everyone at this point to get us, but just so you get a sense of how rigorous the process actually is. So you can go ahead and click to the next slide, Miriam. So we're at the point right now where we've identified these 24 articles, and we're going to move ahead with data extraction, which is essentially data collection for the purposes of already working with published data. So we're building a data extraction template that's multidimensional. It's going to be pulling information from all these different domains that we have here, such as article details, population, description of the screening tool, And eventually the purpose is going to be to describe the nature of all of these screening tools. Kind of a side goal in why we would conduct something like a scoping review is because we've already been in development of a screening tool ourselves and want to ensure that we've identified any sort of knowledge gaps already in the literature where there might be space and an opportunity for our tool to come into place, and what we might need to consider about the current context about how other tools are being used. So eventually scoping reviews are really helpful for informing kind of the future work that we're going to be doing. So you can go ahead and hit the next slide, please, Mario. So once we're done this data extraction, as mentioned, we're going to describe everything that we find in the literature. And a scoping review is useful for comparing kind of the strengths and limitations of existing tools, again, identifying those gaps or what might be missing so we can inform future research. And as mentioned, kind of I'm foreshadowing a little bit in that we've already kind of developed this tool. So we're just using the evidence to show that our tool has a place in clinical practice and provides something unique that other existing tools may not provide. So stay tuned for the findings. This is a work in progress, so something that isn't completed. But now we can see the application of what a screening tool might actually look like in clinical practice when I turn it over to Joel and Mario now. So I'm happy to take any questions, I guess, before we move on to the next presentation, because we will be switching gears a little bit. But yeah, I'm just looking at the chat box here, Chaya.
Great, yeah. I think we don't have any, yeah, I don't think there's anything new that's come in, but I do have a question. I've chatted with Mario as well about this. So I'm curious as to why in your scoping review, you only looked at tools that focused on healthcare professionals who were screening. And the reason I'm just curious about that is because for a couple of reasons. One, we know from families that when they express a concern to a physician, many families experience a very dismissive response. Don't worry about it, your child will be fine. So they don't even get to screening. And most physicians aren't trained in early mental health. So the people who are really doing a vast amount of developmental screening in Canada are actually not healthcare professionals. They're people working in CAPC, CPNP programs. They're working in early on programs in Ontario, Kids First in Saskatchewan. Like, they're working in those community-based programs. So I'm just curious about why the focus was limited, and it's nothing more than curiosity.
Mario, did you want to answer, or do you want me to take a stab at it?
So I think, you know, there are a couple, Chaya, part of the reason why we went with the providers, it's a bit of a chicken and egg thing in some ways, right? If the providers, we talk about in the background, and Ashley talked a little bit on the background, that most of these kids present to the primary care folks. The primary care folks don't have the tools necessary, don't have the training necessary, and therefore aren't able to do, aren't satisfied, many themselves, with the work that they're doing. And so we wanted to really be able to say, okay, what currently exists, and if tools really don't exist, what is it that we need to develop to help physicians and other primary folks, assess those needs and then identify the services that meet those needs versus, dismissing it or not paying attention to it. And I think that's part of the reason why we wanted to focus on that, right? I think there's lots of really good screeners that, parents can complete and others can complete. I think they exist, but we really wanted to develop something that we can help our healthcare providers, better screen.
Okay, so having said that, I'm wondering, and there is a question that's actually come in, this tool isn't going to be limited to use by healthcare professionals. Like, I'm assuming that anybody would be able to use this tool in their screening process.
And so we're going to talk to that exact point in about
Perfect.
2 minutes, Charlie.
Okay, great. Okay. So whoever's asked the question, just know it's coming.
Yeah, so, and
Right.
these are great questions, because I think by virtue of asking that, Chaya, that's almost the answer, is they aren't equipped and they don't have availability of these tools. And so the purpose of the scoping review will essentially be to affirm that and point to the need for something like this. So I think these questions are great, and that's why in the literature we went from 3,200 articles to 24, is because so many of them are administered by all these other individuals, where you almost need a referral to be assessed for something. And so, like Mario said, it's the chicken or the egg. So we want to be able to make it more easy to screen anyone, or any child that comes in where there may be a suspected concern earlier on, and then follow up accordingly.
Yeah,
So,
and I guess the challenge will be, and there is one other question that I want to get to, but just on this point, that in terms of the pathways work, a big part of the challenge is having the services, right? Like, physicians haven't screened this age group. Many will say, well, because what do I do? Like, even if I find a concern, what am I going to do about it? I don't know where to send these kids. So that's a concern. But I do want to raise, because Dr. Carey is also on the line, and he's also asking about, and I'm sure you'll get to this, how you're extracting relational information in the tool. But I think you do, and I think you'll get to that part, but you may just want to highlight that when you are talking about that.
So why don't we, so we'll just move, let's go, for some reason, there we are, there we are, all right. So Chad, if that's okay, then we'll move forward and talk a bit about the Headz under 6,
Yeah,
the
thank you.
And some of the work we're doing with children first. Before I start, my apologies, I should have mentioned that the tool, the websites, and have been translated into French as well. So even though I'm showing you only the English version of it, we have a French version of the tool, and we're actually just finalizing. We're working with a translator on all the websites to make sure that they that they've been translated properly. So we're almost finished the final version of the translation as well. So folks should be aware of that as well. So I'll talk a little bit about some of the work that we're doing with the Headz ED 6 and the Children's First. So first of all, what is the Headz ED under 6, and what does it look like? We wanted to, again, do two things. One, we wanted to keep the mnemonic the same. So it doesn't really matter if Headz ED is a Headz ED, screener regardless of age. The difference is that one is developed for under 6 and one is developed for over 6, and the mnemonic is what changes slightly. So on the left-hand column, and this is, it's hard to read in this particular slide, and I'll go through some of the individual domains in a minute, but essentially it's H now stands for home and caregivers. E goes from, education and employment. Now we're talking about eating and sleeping. Activities and peers stay the same. D, which with the older kids was drugs and alcohol, now is about development, speech, language, and motor. S is about safety of the child. E stays the same as emotions and behaviors, and D is again discharge and current resources. And at the top is the level of action needed. And again, we kept the ratings the same in terms of 0 meaning that there's no action needing, 1 again indicating that there is some action but not immediate, and 2 meaning that there is a need for some immediate action and that there's significant impairment. So just to sort of walk through some of those domains. So for example, in home and caregivers, the typical examples of questions folks would ask would be, and this is up to you to ask those questions. We don't say these are the questions you ought to ask or the probes you ought to ask. It's more as a sort of a guide. So, home, what's it like caring for your child? How does your family get along with each other, and so on. 0 meaning that and it's that there's no action needed, that the home is supportive, that parents are responsive to child's needs, and there's a secure attachment. One is that there's some needs, but it's not immediate, so there's some conflicts, there's some difficulty meeting some of the child's needs, and there may be some attachment concerns. Whereas two, you know, the family situation is chaotic and dysfunctional, parents aren't able to meet the child's needs, and there's potential placement breakdown with severe attachment problems. Eating and sleeping, again, they range from 0, meaning no concerns, to 2, meaning that the child is sleep deprived, there's severe eating disturbances, and there's a failure to thrive. Activities and peers, you know, again, it goes from 0, that it's age appropriate, to 1, there's some restricted range or interest in social and peer development, to 2, where the child is withdrawn and they seem to be unable to function in a social context. Developments, and again, we cluster them together in terms of speech, language, and speak, language, and motor. It's not, we don't separate. Otherwise, we get into a very lengthy screening tool and it defeats the purpose. So we really want to get a global rating or global needs assessment of the development, whether it ranges from age appropriate to some deficits to severe profound deficits in one of the more of the areas. Safety here is, you know, it's really about the safety of the child. And do you have any concerns that your child will hurt, harm himself or others? Is your child in a physical distress, listless, fever, labor, breathing, and so on? So there's no concerns over the safety of the child. There's some moderate level of risk or some dangerous impulsive behavior, some serious health concerns, to 2, meaning there's some imminent risk and some requires some, you know, immediate medical intervention, and that there is some life-threatening impulsive behavior. The child continually runs away from home or runs out in the middle of the street, or the child is significantly failing to thrive. E is emotions and behavior. And again, there's a little bit more on acting out in aggressive behavior for this domain. And lastly, in terms of discharge or current resources, again, 0 meaning the child is already getting services. 1, the child may be getting some needs, but if they're not being met. And 2 is that the child that has no need, you know, is not currently accessing services, or is on a wait list, or has been non-compliant. So that's the way the tool looks like. And I'm just going to back up to it again. So again, it's just a 1-pager. We want to keep it really simple. If you actually went on the website, what happens is that if you put the child's age as 6 or as 5.5, the Headz ED under 6 pops up and not the older one. So it's, again, for simplicity, and the more simple we can make this, the more likely, you know, our primary care providers and we ourselves will use the tool. So I'm going to ask Joel if he can tell us a little bit about Children First, and then I'll walk you through in terms of some of the results we got with the work with the folks there. So Joel?
Hi everybody, it's great to be with you today. I'm very excited to be part of the Under 6 project with the Center of Excellence. Before I tell you all about Children First, I'd just like to thank all of the colleagues that I have at Children First for also being a part of the project and collecting data to contribute to some of the messages you'll hear later on when I'm done speaking. From what you've heard already about the Headz ED Under 6, it fits really nicely with Children First, as we're a multi-service agency providing services for families with children from birth to 6 years of age who are at risk for experiencing mental health or developmental challenges. We have multiple programs and services, from children's mental health, infant and child development, special needs resourcing, where we're in all of the licensed child cares in Windsor, Essex, as well as we're part of preschool speech and language. Across those programs, we're also able to offer various staff services, from resource consultants to psychology, occupational therapy, social work, and speech and language pathologists as well. Our agency prides ourselves on being partners with families right from the time that a referral is received throughout the duration of their service. We really just try to focus on what the family's priorities and concerns are, and that's referrals are received heavily from families themselves, caregivers, but we're also able to receive referrals throughout the community from other partners, schools, physicians alike as well. Next slide, Mario. Throughout 2019, Children First engaged in a quality improvement initiative that was heavily family engagement based. And as a result of that, we made some pretty heavy adaptations to our service model. And what you're viewing here is a visual diagram of our revised service model that took effect late 2019. And each pane here in the blue color is labeled at the top with a phase of service. And this covers right from referral all the way through to discharge. And we've added more administrative support to assist with community referrals. And we've also integrated 2 enhanced phone screeners was in addition to our model. Each of these we have 2 screeners, one with a social work background, another with an occupational therapy background. They work really well together with a dual view of kind of the child, but it really complements our service arrangement nicely with our blended, our programs being multi-service as well. We also added or tried to integrate more of a tier service delivery model as well, where we focus more so on prevention and early identification at the front door, which means not every family necessarily needs the Cadillac of service. Those can be a standalone service option for families where they're able to take part in just that, and perhaps that's all they need. Or other families that are receiving ongoing service may have that as a component of their overall treatment or service plan. But our phone screeners are able to access that right at the eligibility and screening phase. We can waitlist children for any of our multiple programs following that screening that takes place. And the arrows that become very complicated are just different internal pathways. So you don't necessarily need to pay much attention to those for the purposes of today. However, our discipline services are able to get involved at various points in time. Once the child's identified and family for whichever service or services that would meet their needs, they're assigned an ongoing worker who then does additional service planning with them as well. So this is just a visual to outline sort of what's unique for Children First and how we are currently providing services. I think it might lend to some of the data that Mario and Ashley will speak to later to give you some context to how it's been collected from Children First. And I'll turn it over to you, Mario, to elaborate.
Okay. So just picking up where Joe left off, you can see now it's the same diagram, except for there's these 3 orange boxes at the top. And those orange boxes represent different points of time that the Headz ED was administered and who administered them. So there were 3 administrations. The first was at the referral source. So whoever was making the referral to the Children First would complete the Headz ED, but only if they were a provider, not a parent. And then the second one was completed by the phone screener at the time that they received the referral, and they contacted the client. They completed the Headz ED as well as a normal phone screener. And then there were a subgroup of kids who went on to more intensive services, and they had a third administration. It's called the service assessment. And that individual tends to be more of a clinician, would do a much more in-depth assessment that would also include the Headz ED. All 3 administrations of the Headz ED were done independently so that one didn't know the result of the others. For today's presentation, I'm only going to focus on the phone screener and the service assessment screener, mostly because we don't have enough numbers yet for the referral source, and I'll talk to that later. But so as of last week, And again, we began recruiting in the new year, and then had to put on pause because of COVID. And now we're again collecting data. And so we have 206 children that have participated in the study. The phone screener did saw all the children, or at least did the Headz ED on all the children. And then the service assessment was done on 65 of the children that went on to more in-depth services. So a phone screener did a Headz ED on those 65, as well as a second Headz ED completed by the service assessment. So I'll walk you through what the scores look like. So the total sample, we had 206 clients who participated. Our goal, our sample size goal is 500. So we still have a little bit more data to collect, and we're collecting that data. We have about 70% male, 30% female. The mean age at the time of intake was roughly 3.5 years, and ranged from 1 to 6 years. 11% of the children had suspected developmental disabilities. Roughly 60% there was no suspected disabilities, and 30% there was a bit unknown. The referral sources, 72% came from self-referral, and that's part of the reason why we're not including the initial Headz ED, because there was only less than 7% that were being done through connection partners or other community partners, including our pediatricians and other primary care folks. So we're going to come back to that at some other point. And there's some coding issues that we're trying to sort out as well. But the vast majority of the children presenting to Children First do come from self-referral. We looked at, we compared on age, sex, and suspected developmental disability between the kids that were screened but then didn't go on to service screening to the service assessment. So those were regular versus more of the additional service. And what the big difference we found was within age. So the younger children, the roughly 3 kids that were the average age of 3.6 or 3.5 years old, tended to only have a phone screener, whereas the kids who are a little younger, 3 years of age, also were referred on to a service assessment. So they tended to be a little bit younger. Now, looking at the Headz ED scores, the one thing you'll notice is that if you look at that graph, is that the distribution of scores kind of looks like what you might think it ought to look like, that there are some children that present with less needs, and some children present with a lot of needs, and then most of the children kind of cluster in the middle, with our mean age is roughly 4, and the scores ranging from 0 to 10, with 5 being the median. So these are all the kids that were not, these were the kids that were not referred to further assessment. If we take now a look at the kids, that 65 children that were referred on for the additional service assessment, and you look at that graph, it's a little bit different. It doesn't quite look as nice in terms of the distribution, but you'll also notice that there's a little bit more of the a flattening of the curve, and there's still lots of kids on the far right. But the overall scores were no different. So if you look at the third bullet, clients who were referred for service assessment were not significantly different on the overall Headz ED score compared to those who only received the phone screener. So that's something to keep in mind, because ideally you would love to have seen a huge difference, right? So no, those kids presented, with much greater acuity and much higher scores, and therefore, they clearly were different. But that's not what we're finding so far. And in fact, when we take a look at, this is a very dense slide, but if you take a look at the very top in terms of 0, 1, and 2, and you look below, it says those 141 that were only done by phone screeners versus the 65 that were referred on to a service assessment. And now you go to the bottom of the graph. The one thing you'll notice is that the children who were referred on to more in-depth the service assessment presented with much more emotional and behavioral problems in addition to some of the other challenges. So that's one thing that we noticed. And if you take a look at the services that were recommended at the time of intake, the vast majority of children were referred for regular services and not priority services. And if we take if we now look at the scores on the Headz ED, comparing the children who were referred for regular service versus priority service, so not whether or not they were going on for additional assessments, what you found is that the mean Headz ED score was significantly higher for our children and youth, for children who were recommended priority services compared to those who were recommended for regular service. So we're finding that the Headz ED was able to separate or distinguish, you know, higher service need versus lower service needs. If you take a look at the distribution of scores on the Headz ED, these are the ones that were completed by the clinicians doing the service assessment. Now you find that their scores are a bit higher compared to the Headz EDs that were completed by the phone screener. So the service assessments, you know, tended to rate the acuity of needs a little bit higher. And in fact, the mean total score, if you look at that third bullet, at service assessment was significantly higher compared to those that were completed by the phone screener. So the next slide kind of captures it. Again, at the very top is the Headz ED domain from 0, 1, and 2. And if you scroll down at the very far right, you'll notice that the service assessment screen identifies much more needs in terms of all the domains for the children. So the service assessors, same child, done a little bit differently, found a greater acuity of needs. So the question is, why did we find those differences? And I think that's something we can talk to in the next couple slides. So this is the types of recommendations that were done at the time of service assessment. So not the phone screen, at the second one. And again, you can see the distribution in terms of some of the scores. And interestingly, again, the mean Headz ED score for recommendations for regular service as recommended by the service assessment was significantly lower compared to the Headz ED score recommended for priority services. So big differences in terms of those two scores. The regular service was about 4.7 on the Headz ED compared to 7.9. So that difference is significant at P less than 0.001. So what's the main summary of the data that we're presenting so far? I think the initial evidence shows that the Headz ED tool under 6 that we've developed might be clinically effective as a quick screener, particularly useful when we're trying to distinguish, you know, those children who do require more intensive services versus those that require higher priority services, and those who present with more emotional and behavioral problems. So the tool is talking to where we think it ought to be, is really addressing the issue that is really meant to address, which is 1, can identify need, 2, can it identify the types of service that are commensurate with that need, and will it help to guide decisions in terms of what sort of services the child would really require. And I think it's certainly speaking to that, at least initially. Lots of work still needs to be done, even with our project with the folks, with Joel and Lori and the other folks at Children First. We do have a sample of 500 that we want to get to, and we anticipate that we'll probably get to that in the next several months. So we're well on our way, I think, we've inputted a whole bunch of additional data in the last little bit. I think we're close to over 300 at this point. One of the things we want to look at is that inter-rater reliability. Why were there differences between the phone screener and the service screener? And so the question is it because the phone screener just is, they tend to be clinicians and social workers, and therefore spent more time kind of drilling down in terms of the acuity of the need, and therefore they were rating 2s instead of 1. So is this an opportunity that requires a little bit more training in terms of what's a 2 and what's a 1? And might be a little different for the under 6 compared to the older kids, and being able to make that decision. So we'll need to think a bit about that, and our data will kind of, as we increase our sample size, we'll be able to better tease that out a little bit. The one thing that we'll also need to do is really try to think about what are the clinical cutoffs as well as the scale sensitivity and specificity. So for example, in the Headz ED, in the older children, we have a cutoff of 8. So what's the cutoff that we should be using just as a general cutoff in terms of saying, you know, this child ought to be You know, we ought to be thinking of more intensive services for child A versus child B, and what does it look like in terms of the sensitivity and specificity of the measure. The last thing we're going to do is look at the relationship between the Headz ED as well as the more intensive assessments like the Inter-I, and how they map onto each other. In the meantime, we have developed a you know, a website for the under 6 as well. It's not, we haven't, you know, it's not available quite yet. We haven't published it, or it's, you know, we haven't made it live yet. And we're kind of mindful of the fact that again, the tool is beginning to show us some real promise. We're going to keep validating the tool. We hope that if people, you know, want to use the tool, that they just let us know. The website is also being translated into to French, so that it will be available in both official languages, and that I think it'll, you know, now that, you know, we've all gone virtual, I think, you know, being able to have the tool within that virtual domain, it will be tremendously important, particularly when we think back to a slide way back in the primary care pathways, where we looked at, you know, the pandemic came around, and then we had a huge fragmentation of services again. And I think, you know, part of the reason is that a lot of the tools that we're using tended to be very paper-based still, or tended to require information being faxed. And so the web-based version, you know, will facilitate that integration, because the tool can be completed online and in a secure, website, and the information can be transmitted using a secure, again, portal, so that those linkages can be maintained. I'm going to stop here because I know we're almost at the end of our time, and I wanted to, leave some time to have a general discussion and answer any questions that you folks may have. So thank you for being part of this webcast.
Great. So one question is actually for Joel, and people are wondering, Joel, if you can speak to the challenges that children first experienced in the implementation of this tool.
Great question. I think with any implementation, there's certainly always challenges. In our case, I would say the benefits of as a multi-service agency is certainly outweighed the challenges. I know in speaking with Mario and the team, one of the things that we're sort of challenged by right now is we had switched to the Headz ED as a referral tool, referral form. And I think in terms of the project, it's been a little bit difficult to replace that with our physician and community partners. And that would probably be the primary challenge, is to get that back from physicians or community partners. And it's also been exacerbated by COVID-19 and people not necessarily having access to fax machines and some of the other technologies that way. Mario, I know we've spoken a little bit about other challenges. Is there anything I'm not thinking of?
No, I think that's, I think the challenge will be, again, we're going to develop the tool, and it's the same thing with our Headz ED tool, is that creating those pathways to help, primary care folks, understand, the needs of these children, and then being comfortable in asking those questions, and then being comfortable in terms of sharing that information so we can act on it in a more efficient and integrated way. And I think, again, the idea is that, what we found is that, and I'm just going to, if past behavior is the best predictor of future behavior, then, in our primary care pathways, when we created the tool, we gave them the tool, we had really good uptake. And so I think part of it here is to be able to create the tool, and then I think we would anticipate good uptake. And then if we have a good pathway, then again, I'm hopeful. but it has to, but I think the other part too, we have to think about the pathway within that kind of virtual electronic space.
Okay, great. I have a couple of questions, Joel, as well. And I don't know if it's Joel or both of you. It feels like your number of infants is actually low in your sample. And so, because your mean age was 3.5, I think. So are you going to do anything to try and get your practitioners to use the tool? Because it can be used, right, with 0 to 1-year-olds.
Yes, I think that's certainly a trend. When you look at all of our programs, the one program that certainly services the younger children is our infant child development program. And the average age there, when you look at that program as a whole, it tends to be around 2, recognizing that's not necessarily the younger ones, but again, keeping in mind it's an average. We've been doing a lot of work in our community using community approaches or collaborations to try to ensure that we're certainly getting to those younger children and that they're being referred. But again, we still say, where are some of those younger children? You're absolutely correct.
Okay. So,
but we do find that the tool does work well with all ages under 6.
Yeah. Great. And I just want to confirm, so in terms of the screeners who were using the tool in the study, they in fact weren't physicians, or were some of them physicians? Like, I'm just not clear on who. It sounded like you had a, sorry?
So Chai, can I just ask what you mean, like a time of referral or the time of screener?
No, the screener themselves, like the person who was using the Headz ED questionnaire. Who was that person?
Our screeners that are part of our centralized intake department are there's two of them. One's an occupational therapist, the other is a social worker.
Right. So I guess it brings me back to just the question of, like, I know you're trying to design this for primary care physicians, but even at your agency, it's actually somebody other than that who's using it. So I just know that a lot of people who are listening to this session, Mario, are not physicians. They're not necessarily in the healthcare sector. They're loving what they're hearing. And I think that you would get those infant numbers up if you reached into some of those programs, is all that I'm getting at.
So Chai, I agree. You know, I think when we, you know, the original development was meant for, you know, physicians, right? You know, when we created the first Headz ED, and clearly it's gone way past that. And I think with this tool, it's the same thing, that we talk about it as a primary care, but it doesn't have to be physicians. You know, primary care can be, you know, at the primary care setting, it could be the nurse, could be the OT, could be one of the other folks. And so for us, it's really about a clinician, you know, a use, which is different than a parent use of the tool, right? So our centralized intakes and our intakes, you know, they're still clinicians, right? They may not be, but it wasn't designed to be completed by, you know, by the parents. That's the only, you know, I think, you know, thing that we want to be clear on.
Right. Yeah. No problem. Okay.
And if I may add too, if you think back to the slide that Mario had shown with the yellow boxes on our service delivery model, we are receiving referrals from physicians who fill it out at a referral point in time. And I think what's interesting, as it's been alluded in the chat, that I'm on the ground, or Children First is in the field. What's really helpful from us, from a clinician perspective, is when there's some continuity or predictability between the physician referral or intake person and the service, so that they're all speaking the same language, or at least tapping into, maybe at different levels, but saying the same thing. In doing so, when that happens, we could be much more efficient in actually getting to services based on need identification. And in a multi-service environment, that can be very complicated. So it's nice. I'm really excited for part 2, where some of that predictability, as you've alluded to, Mario, will tend to take more shape.
Yeah, I think also, just because some discussion on the chat about the ages and stages has come up as well, I just want to clarify that the Headz ED is really meant for when a family comes into, you know, a clinician's office or someone's office and says, I'm really worried. Like, I have a concern about my toddler's emotional development or something, or behavior. I mean, typically they'll say I have a concern about behavior. The ASQ isn't really meant as a tool that gets used only when there's a concern raised. It's really meant as almost as a preventive tool, like we're looking at development. So I just wonder if you can clarify, Mario, because people are asking, you know, could you use these two together? And I'm like, you could use this one first, and if there are concerns, the ASQ or any number of other tools might be the next level of assessment.
So I think, again, you know, you pretty well answered it, Chaya, that, you know, the tool's really meant as a general screener, right? And then I think from there, you then go on to more, you know, either more in-depth screening or more specialized screening. So I think that's where the ages and stages questionnaire would fit in, right? And as well as some of the other ones. But I don't think, in my mind, I always see these as complementary. And it's more a matter of how do you tier them so that you don't, you know, you can easily, you know, as a provider and as an agency, you can make some decisions early on in terms of the, you know, the type of assessment and type of services that the child requires, so that you don't, so that it really meets the child's needs, right?
Right.
So I think
yeah, one of the things that's being, you know, sort of raised a little bit by some folks is just, you know, putting it in the hands of like Healthy Babies, Healthy Children. You know, it's nurses and it's a home visiting program.
Yeah.
Is that something you would explore down the road? You know, somebody from BC even asking, like, can this get into programs that are delivered by by public health nurses, which are typically home visiting programs?
I think that's a wonderful suggestion.
Yeah.
And I think that's where, you know, if you ask, you know, any of us who are who are mental health service, you know, folks, you know, ideally you'd like to be able to do screening. That's the whole point. You know, the issue of developing a screening tool is to be able to screen at a population level, so that the kids who require service are identified early on, right? And I think, you know, the ability to sort of put it into the hands of public health nurses and other folks, you know, who work with these children early on, you know, that would be, you know, clearly the more preferred, versus waiting until they get referred to a more of a tertiary or secondary service.
Yeah. Okay, I think we're actually at the end of our time slot, and I think people are just so excited for the work that you guys are doing. They're excited to get their hands on this tool. I think people are probably going to be in touch with you, following up. So
I'm getting emails already, by the way, Chaya.
Yeah, I'm not surprised at all, Mario. Not surprised at all. So, you know, and I'm going to be emailing you as well, because I have communities that we're working with that I'm thinking, oh, they would really love this. So I think it's exciting, and I think stay tuned. And to the audience, I think, you know, we have a great relationship with Mario and his team in the Center of Excellence. And I think when there is new information to report, we'll probably try and do another session like this, so that we can get Mario firsthand to share that update with you. So thanks very